audio, or other formats was created for informational purposes only. Now, the content is not intended to be a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Inspire RTINC does not recommend or endorse any specific tests, physicians or products, procedures, opinions, or other information that may be mentioned. Reliance on any information provided is solely at your own risk. Hey, welcome to the Gas Exchange. Finally, we've been doing our company, Inspire Respiratory Critical Care, nonprofit focused on providing educational opportunities to folks, doing panel discussions, daily pearls, etc. We've had this sort of podcast in the works, in the planning stages for quite a while now. I've been doing this stuff for about 2 years. This is episode 1. We're super excited, and we're going to do topics that are real clinical, bedside, take care of real patient type topics, and we're super excited about it all.
Just to be clear, you've been in RT for more than 2 years, though.
2 years.
I've been doing this stuff for 2 years.
Yeah.
I know you mean Inspire, but sorry, I had to start making jokes.
I think about 28 years now, which is
okay. I think it's a good intro. I think it's a good intro for the first episode. Let's establish how long we've been doing this stuff.
That's good. 28 years.
The other stuff, the actual content stuff, yeah.
How about you, Thomas? How long have you been doing this?
I graduated in 2003, so almost 23 years.
Eric?
97. I am 20. This is year 28.
Wow. 97 is when I started school. 97 is when I started school. I got off active duty in the Marine Corps just a few months before. And well, got a little off track, but that's great.
Yep, sorry.
So anybody who's listening or who's watching, we've got a couple of years of experience on today's show.
You're old.
So,
we're old.
Starting with you, Keith Lamb. Remember,
Yes,
we're listening.
Keith,
People can't visually see you and your name. So,
well, if you could see me, you would know I'm old, but I sound not too. We'll let you be the judge. So, co-host Thomas Prano is my co-host, and he will be here to help me with these episodes. And our first guest is Eric Kriner. We already decided that he has been doing this for quite some time. And our first topic is going to be PEEP. Now, we appreciate
the elusive PEEP.
How do you even, I can't even spell PEEP. Anybody know how to spell PEEP? So what is PEEP? Positive end expiratory pressure, right? Positive end expiratory pressure. How do you choose PEEP, Thomas? How do you know?
That's a good question. So, when you're a student, you get taught essentially starting parameters for every patient, and I'm going to guess that most people get taught to set a PEEP of 5.
Whoa.
I would argue that as the years have gone on, the more you learn, the more you understand, the more you start maybe changing your standards. So I have how I select PEEP, at least initial PEEP. If my patient is, let's say they're requiring intubation due to respiratory failure, more specifically, a little bit of hypoxic respiratory failure, I would not start on a minimum PEEP of 5 myself. In fact, I will put what I consider the new 5 for most patients. I just wrote it on a piece of paper.
I just wrote it on a piece of paper too.
Okay, so Eric, do you have a piece of paper? I know for those listening, you can't see the piece of paper we're about to hold up. We will tell you what the numbers are, but we're going to hold up our numbers on the count of 3. How about that?
Wait a minute. Okay. Before we do that.
So
the number you have written on that piece of paper is the amount of PEEP that you would start somebody with hypoxemic respiratory failure or anybody?
Yes, as a minimum, and then we can talk about other things I might do to adjust the PEEP or to assess that PEEP, but it's going to be this is my new starting point when my patient is intubated for hypoxemic respiratory failure. And I'll talk about other potential conditions, like let's say we're doing, like, if I was helping someone in the OR, I'll tell you what PEEPs I would choose for those patients.
Or if somebody has a BMI of 50.
For sure. Instance. Absolutely. We'll definitely get to that. But let's say regular patient, normal BMI, They're on high flow nasal cannula. They're failing. We intubate. We're putting them on the ventilator. Are we going to hold up our numbers? Ready? On the count of 3. 1, 2, 3, go. All right. So I got a number 10. Eric, yours is being hidden by your back. Okay, you got a 10. And Keith has 8. All right. So we so
who would have thought that Keith would be the conservative one here?
Yeah, you are. Yeah, you're a little conservative with your PEEP. So yeah, so 10. So to be perfectly honest, I can't remember the last time that a patient I had that was intubated for respiratory failure, I would start them on a 10 on 10. Now, just for your benefit, Keith, because you chose 8, if I put them on 10. There's a couple of things I would first pay attention to. And I know driving pressure is not specifically related to, but of course, PEEP can impact driving pressure. So I would look at the driving pressure. And the funny thing is, if the driving pressure was high, my first reaction would not be to lower my PEEP to 8. I actually would assess for something called airway closure, which is probably going to be a topic of another podcast. But airway closure can give you erroneously high driving pressure values. So you might think that the PEEP of 10 is actually bad because the lungs appear stiff, the driving pressure is high. You might think, oh my goodness, I need to lower my PEEP. Now here's the trick. If you lower your PEEP and your driving pressure goes even higher, that kind of tells you you're probably dealing with airway opening pressure. Whereas if you increase it and your driving pressure is coming down, then you know that you're probably dealing with airway closure. But 10 would be my start. I'm glad, Eric, our first guest is on the same page, and Keith is just a little bit more conservative. He's a little bit more kind.
Lagging a little bit behind. Now, let me just defend myself a little bit. When I wrote that number 8 down, I was thinking about across the board. For me, 8 is the new 5. This arbitrary number of 5, we've discussed this before, is sort of just this made-up number. Off topic, but there are a lot of made-up numbers in critical care. I don't know if you know this, but I was talking to a surgeon not that long ago, and they said this hemoglobin of 7 is a made-up number. You know how we have this transfusion threshold of 7 of a hemoglobin. Yeah, that number is completely arbitrary and made up. Anyway, having said that, I was taught years and years and years ago that there was a physiologic PEEP of 5, and when in fact there is no such thing in my mind as a physiologic PEEP. And so this number 5 is sort of made up. But having done a lot of esophageal manometry, done a lot of reading, late night reading, done a lot of looking at morbidly obese patients and how much PEEP they require, and sort of just understanding that the average BMI of an American ICU patient, male ICU patient, is about 30. And if you look at I know you guys don't necessarily believe in this data, and there's not a linear relationship between, a real linear relationship between PEEP and BMI, but there's a relationship, and the higher BMI, the more PEEP you probably would benefit from. And so for me,
I wouldn't say probably, I would say absolutely.
Yeah, absolutely.
Yeah, like I have,
So 5 of PEEP is, if the average BMI is 30, 5 of PEEP is probably not right.
So I'll play a little devil's advocate. So what if peri-intubation, you are profoundly hypotensive? And I think we understand the reasoning behind that peri-intubation hypotension, right? But that's a gut clenching for a lot of people in the room, right?
Lower gut.
Yeah, lower gut. I was trying to find the right anatomical position. I went a little high. Yeah, that is a big argument that is had a lot. You have a profoundly hypoxemic patient, clearly intubated for hypoxemic respiratory failure, not necessarily cardiovascular collapse. You go through the process and you come out the other end, and you have what looks like big limitations in applying the pressure.
Yeah, I would say that I totally agree with that, and we do have this discussion at the bedside often. And my response to that typically is it depends on why they're hypoxemic, right? If they're in shock and hypoxemic because they have a massive saddle embolism, that's a different animal than somebody who's got massive alveolar consolidation from trolley or from volume overload or from this acute inflammatory process that's that's causing an alveolar. So if it's the latter, if it's this alveolar process, then I would use the PEEP that I think that I need to use and then treat the shock. If they're in shock from an obstructive etiology like a pulmonary embolus, then I think that there's something to be said for being judicious with your PEEP until you have the problem sort of sorted out.
Yeah, I'd probably say the majority of the time, it's not the PEEP of 10 that you've selected. You know, so my response, because this has happened to me clinically. I know it has because many times I've set PEEP not 5 in a person who's hypotensive. And my reaction to them is like, you deal with the blood pressure, I'm dealing with the lungs. And I said, I understand there's an interaction. I said, but I guarantee you, if I put an esophageal pressure in this patient right now, I'm not distending the lung with a PEEP of 10. How do I know that? Well, there are multiple studies looking at baseline pleural pressures in like surgical patients going, like just normal patients, otherwise healthy, going in for surgery. And for patients with low BMI, the average pleural pressure was 6 centimeters of water. So if I had set my PEEP at 10, I'm +4 on my PEEP. Again, this is a healthy patient. Chances are this person in the ICU is likely not a perfectly healthy person who's just coming in for surgery that day. So going to 10, let's say their pleural pressures were 8. Now I'm +2 in terms of transpulmonary pressure. I know this is another discussion, but for those who don't use esophageal pressure, we do know that the transpulmonary pressure is what determines the distending pressure of the lung and the potential for injury and the potential for cardiovascular impact, et cetera. Just the pressure alone doesn't impact anything unless it's distending, unless it's stretching, essentially. So I feel 10 is a pretty safe. Now, if I had chosen 15 of PEEP or 14 of PEEP in a patient who wasn't obese, and we'll talk about that in a bit, then I could see some concern. Again, if I can't determine quickly enough that this is because of airway opening pressure or airway closure, I would then, for example, decrease my PEEP momentarily and say, listen, I'll turn the PEEP down. How long do I wait before we realize that this isn't a PEEP problem? Because if you reduce the PEEP, is your hemodynamics expected to change drastically? And how long should it take for that to happen? And if there's zero change, you could have that discussion. But I think the problem is that most people that are put in these situations don't have the knowledge or the background to argue this. And I don't mean knowledge in a negative sense. I just mean like, if I'm going to start arguing distending pressures, I need to understand what that means. I need to understand what PEEP means in the concept or in the context of lung distending pressure. But if you can't argue that eloquently at the bedside, and I don't mean argue in a negative way, if you can't discuss this or disagree and have this discussion academically, then you're probably just going to be like, okay, and just turn the PEEP down to 5. And that's unfortunate because you're essentially going to lose arguments. Again, I hate using the word argument. You're going to lose discussion points if you can't back up your thought process. So just saying, oh, I heard these guys on a podcast, they start everybody at PEEP of 10 except for that Keith guy, he starts 8. Then that's not the kind of discussion you're going to have at the bedside that they're going to care. They're going to be like, I don't care, turn the PEEP down, right? And I think this is a problem that many people face, is that you have another opinion in the room, and it's typically the ICU attending or the emergency room attending, whoever is having this discussion with you may feel like they're right and you just need to turn it down.
Yeah, so eloquently being able to eloquently defend your position in terms of dosing. I love Kriner's the one who taught me that term years ago, and I use it all the time. Dosing the ventilator to the patient, like dosing the propofol, dosing the norepi, etc. Dosing the ventilator to the patient. It's a shame to lose your argument points, but it's also a shame because it's not the right thing to do for the patient. Right. And so being able to eloquently sort of defend your position. What if I have to give up? I mean, is there a bulk way of discussing this quickly at the bedside that doesn't make me have to backpedal?
What do you think, Eric?
Well, you need to keep your job, right?
Yeah, you don't want to get written up for being difficult.
Yeah. And so I think in all the difficult positions that I've been put in those, I think there is the acquiescence that with I always and I refer to it as I'll set up a goalpost. And so if this was the case, I say, okay, I hear you, I see you, I hear your concern. Let's turn the PEEP down. You work on blood pressure. Let's not forget about this. And let's give this amount of time before we then come back to the question at hand. What is the adequate dose of PEEP in this particular patient? And promptly readdress it. I think leaving it go, and now it's 4 hours later and you're wondering why you're completely struggling and still behind the eight ball, is where you don't want to leave it, right? And I think, being able to maneuver your way in that politically correct and empathetic conversational way is a way through there, right? Is saying, okay, I get you, I hear you, right? And sometimes that is where I'll end up. There are these concerns.
I think you bring up a good point that you need to establish, like, what is the specific time frame at which we can then allow me to focus on the lungs. Yeah. Because I think I personally, just clinically have seen this over the years of practice, that, these decisions that get made to lower the PEEP so that we can deal with the hypotension, you're likely taking care of 6 or more patients, depending on the acuity of your ICU. So then that patient, like, you can't rely on somebody else circling back to be like, okay, good, the blood pressure's decent, let's deal with the PEEP now. You have to follow this up, and this can be challenging for the clinician that's looking after 6 or more patients to, like, come back and be like, oh yeah, now I need to assess, whether or not this patient is tolerant of PEEP. So that's the only downside to not giving up your stance, but compromising in a way where we say, okay, well, let's change the goal for now, but let's reestablish. And then the question is, like, does the reestablishment or the relooking at it, does that happen in a reasonable time frame? And that's where clinically becomes challenging. So again, I encourage respiratory therapists or clinicians to learn the knowledge and understanding to make their arguments, so that they're not having to sacrifice something now to then try to make up for it later when you have the time. Because again, likely that little bit more PEEP, whether it's 8 if it's Keith, or 10 if it's you or me, that little bit of more PEEP is probably not causing the issues. They're likely going to get resolved by dealing with blood pressure in the way that they're used to dealing with it. But if we compromise and put them down to the lowest PEEP that we'll accept in that ICU, which is likely 5, then it's a matter of, like, okay, how long does this patient end up on a PEEP of 5, potentially inappropriately, before it actually is reestablished and this conversation happens again. And I think that's where we sort of lose out, that it's great concept, great idea to come back, but, like, you hope that you have the time to do it.
Yeah, all really good points.
So before we go, let's see if we can't paint, like, a mind's eye picture of distending pressure. So you had brought that up in the context of transpulmonary pressure. So if someone were to close their eyes and be able to describe distending pressure, or even the relationship between pleural and alveolar pressure, like, what would that look like? What do you see?
Some of the concepts that I've used historically to describe transpulmonary pressure or distending pressure, for those that, if I don't have a visual aid, is, I'll give you the example of a balloon, because we often use that as an example to explain compliance. We'll say, like, when you try to blow up a balloon, sometimes it's difficult to, like, get past that sort of critical opening pressure of the balloon. But then once you do, the ease at which you can blow it up is the compliance. And some balloons may be stiffer, some may be super floppy, like a plastic bag. You minimal blowing into that and you're going to inflate a plastic bag. Whereas balloons have more elastance, less compliance. So they're, again, a little bit more force and pressure. I used to say, that's great if we didn't have a chest wall. And just imagine that the chest wall represents not just the chest wall, but also the pleural pressure outside of the chest wall. Because your chest wall may be compliant, but if you have elevated pleural pressure because you're lying on a bed, or you have morbid obesity and you just have this extra pleural pressure that is decreasing your FRC, what I say is that the pressure that you're putting into the lung, imagine you put a balloon into a box and you're trying to blow up with the balloon, but you're hitting the box. You will generate more and more pressure as you try harder and harder to blow up that balloon. You could be reaching pressures that you would never ventilate a patient with, but the balloon is not moving beyond that box. So you're not you would never blow a balloon if you cannot expand the balloon. So the whole idea is that when we set PEEP, we don't understand how much counter pressure there is. Like, what is the pressure from outside of the lung that is impeding the pressure I'm giving inside the lung from actually stretching and distending? So again, it's hard to visual. This is why most people use visual guidance or visual tools. Like, I've had a video online for years of just a test lung inside a water bottle, and I have CPAP pressurizing outside the water bottle, and then the test lung is just being ventilated with normal ventilating pressures. And at PEEP, if I turn the CPAP outside of the balloon, if I turn that up to 12 and my PEEP is 6, you see the test lung just collapses, because at end exhalation, the amount of pressure outside is so high that it's actually impeding the expansion of that balloon with just 6 centimeters of water. So really it's just a matter of, like, when we apply the pressure at the bedside, it doesn't mean that 10 centimeters of water is expanding that lung, right? Mm-hmm. You could have, if you sit on, not that you would, but if you sat on a patient's chest or put weights on the patient's chest, and you try to add pressure, that pressure has to overcome that force to expand the lung and to increase end expiratory lung volume. Well, not increase end expiratory lung volume, but to increase FRC, you would need to open this up. End expiratory lung volume will always increase when you turn up PEEP. But whether or not it expands the lung really comes down to the distending pressures that you're dealing with. But I don't know if that makes sense. Again, it's one of those difficult things visually, but I just say, like, imagine trying to blow up a balloon that's in a tiny box, and you just cannot, no matter how much pressure you add, it just does not extend beyond a certain amount. Now, obviously, you're not going to keep cranking up PEEP, but the bottom line is, if you set a PEEP of 10, it doesn't mean PEEP of 10 will be different in every single patient based on pleural pressure. My choice of 10 is because I mentioned earlier, in surgical patients, the average low BMI pleural pressure when you sedate and paralyze a patient for surgery is like 6. And in obese patients, these patients, the average, again, in these healthy individuals was 12. So 6 and 12, I'm just choosing a number sort of in between that, expecting most of these patients aren't healthy, and choosing 10. I'm going to be somewhere within that range where the PEEP that I apply is going to be as close as I could guess their pleural pressures being. So I'm just trying to push against that external force to be like, okay, if the external force is 12, if I get to 10, then I'm only 2 centimeters away from that external force, right? I'm probably keeping the lungs somewhat open. And obesity is a whole nother concept, which you kind of touched on, Keith. But in those patients, likely it's even higher than that.
Right.
Yeah, I use the balloon inside of a balloon or a balloon inside of a water bottle in the same way. And so if you said distending pressure, and we used the numbers that you gave us, and we said normal distending pressure inside of the water, or normal pressure inside of the water bottle is 6, and we put 6 of PEEP inside of the balloon, then there's no distending pressure because they're equal, right?
Right.
And if we turn the PEEP to 7, now the distending pressure of the balloon is only 1 above what is in the water bottle on the outside. And so that's
right. So you're only in excess of in terms of excess of what would be required. Now, I'll sort of backstep, because anybody listening is like, yeah, but the lung isn't one balloon. You're right. It's not. We have pleural pressure gradients, but the whole idea is that the distending pressure example at PEEP is often best described in this concept, or in this context of, like, you have a balloon, and if the pressure outside the balloon is higher, it's going to collapse. If it's equal, it's going to just stay sort of open, but like not distended. It's going to have 6 centimeters of water pressure, and that's going to have volume with it, and it's matching the pressure outside. And the minute you start going above that, you start distending the balloon more than that resting pressure. It doesn't mean that that's injurious. It just means that you're now overcoming. Now you have a distending pressure rather than just a neutral opening, essentially.
Yeah. Let me. Fellas, let me bring us back to, we're going to have an entire episode devoted to esophageal manometry balloons, and that's that particular method of evaluating some of the things that you guys have just discussed. But let me bring it back to the bedside clinician who doesn't have esophageal manometry. Maybe we're going to talk about EIT at some point in time. We're going to talk about ultrasound. We're going to talk about other imaging in terms of using those things to evaluate for appropriate dosing of the ventilator. But let's bring it back down to the standard issue clinician at the bedside that needs to figure out how best to take care of the patient. There are certainly deleterious effects from not having enough PEEP also, right? And we know that when we have episodes that talk specifically about ARDS. We'll get deeper into this, but most mortality is caused by secondary inflammatory processes and multi-system involvement, not the respiratory failure all by itself. And some of that inflammatory process is caused by things like atellect trauma and not being on enough PEEP, that stress injury that happens to the alveoli that sort of open and close, and those inflammatory cascades that occur after that involve multi-system organ failures. There's such thing as not enough PEEP, and there's such thing as too much PEEP. If I am at the bedside and I don't have all these fancy tools, you guys have already told me that and I agree with the 10, to be honest with you. 8 is just everybody for me. If somebody's hypoxemically, is that a word? I don't know. I'm not sure if it is now. The gas exchange, that's a name. That's a word. If they're in hypoxemic,
you're hypoxemically challenged. You're hypoxemically challenged.
Poor thing. Then I use more, obviously. But what do I do if I don't have all of this stuff, all these things that we eventually will talk about available to me? You've told me you started at 10. Without getting too deep into driving pressure, because guess what? We're going to have Marcelo Amato on in the near future talking about driving pressure, and we'll get a lot more into the person that he didn't invent driving pressure, but he certainly talks a lot about it.
He brought it to the mainstream, you could say, yeah.
Tell me a little bit more about how you set PEEP based on other physiologic measurements that I can do right at the bedside.
Go ahead, Eric.
Well, unfortunately, it is largely following that driving pressure.
I was just going to say, I'm going to let you go because I was just going to say, I was just going to say, do a plateau pressure and
I think
look at driving pressure.
Sure that just an oxygen surrogate is where you need to stop, right? And I think a lot of people start and stop there, and that's where they get themselves into trouble with managing PEEP. Is I've put my PEEP to this and my SAT is this, and I've been able to titrate my FiO2 downwards here. And we can play that game that, I'm still above whatever number that your practice kind of says is the cutoff. I'm still above 60% oxygen. And so therefore I'm going to interpret that as alveolar shunt, and I need to increase my PEEP so that I can now downward titrate my FiO2. And if you get off the ground in that way, I think you're okay. It's not a bad starting point. But to only do that, I think is the mistake that you make, right?
Yeah, I think we're probably going to bring this up in multiple episodes, but let's think back to ARDSNet. Yeah. ARDSNet 12 mils per kilo versus 6 mils per kilo. The patients with larger distending tidal volumes had better gas exchange, not just oxygenation, but ventilation, of course, because your minute ventilation will be greater. So they had higher mortality. So we know that oxygenation is, when it improves, when we increase PEEP, we feel fantastic about it, but we have to understand that this is not a good physiological measure of outcome. And sometimes you can get improvements in oxygenation and it's actually deleterious to the lungs. It really just depends on how this oxygenation improvement is happening, because you can change shunt and improve oxygenation with overdistension in some cases as well. So I think back to what your first response, which would have been mine as well, if we set a PEEP, let's say we start at 10 and we measure driving pressure, and the driving pressure is, let's say it's also 10 centimeters of water. So my PEEP is 10, my plateau is 20. I'm going to feel quite confident if my patient is still requiring high FiO2 to increase my PEEP further. 2 to 4 centimeters of water to start, reassess my driving pressure, and just see where I'm at and see if oxygenation improves. I wouldn't continue to chase this oxygenation idea and get up to a PEEP of 20. Again, we can talk about obese patients later. Let's just assume this patient doesn't have a BMI above 40.
Because then your plateau pressure isn't.
Yeah. And then, driving pressure can still be useful in these patients, but this is the point of now let's reverse that. Let's say I had a PEEP of 10 and my driving pressure was 20. Knowing what I know, my first response would be is this airway closure? I would be why, unless it's known why the patient would have such stiff lungs. If the patient has underlying pulmonary fibrosis, then clearly you're expecting ridiculous driving pressures likely on any PEEP, and you probably wouldn't start at a PEEP of 10 someone with fibrosis, like known pulmonary fibrosis. That's the one caveat I should say, back up. Like 10 for everybody, but if you have pulmonary fibrosis, I'm probably going to start you at 5 and measure your driving pressure immediately, and then see if increasing PEEP makes it worse. And if it does, because I have treated fibrosis patients with PEEPs of 5 or less, depending on how bad their fibrosis is. But back to my point, if I put them on a PEEP of 10 and the driving pressure was 20, my first consideration would be, is this airway opening pressure? Now, if you don't know how to do that maneuver and you've never done it, and you don't know how to check for airway closure, then I would essentially do a very quick PEEP test. If I increase my PEEP by 2 or 4 centimeters of water and my driving pressure comes down by 2 or 4 centimeters of water, that answers my question. I'm doing the right thing. In other words, my plateau pressure is not changing. So if your plateau pressure stays stable as you increase PEEP, by definition, you are reducing driving pressure, and likely it's not deleterious to the lungs. Whereas if I'm increasing PEEP and my driving pressure is going up, that's not a good thing. If I'm increasing PEEP and my driving pressure is staying the same, who knows? We're in the linear curve of the pressure volume curve, essentially, right? Driving pressure is not changing. I'm not hitting an upper inflection point likely. Whether or not there's benefit, who knows? But the minute that driving pressure starts to increase as you increase PEEP, that's where you have to wonder whether or not. And again, I'm not saying plateau pressure, because if I increase PEEP by 2 and I'm in the linear part of the pressure volume curve, if I increase PEEP by 2, my plateau pressure should go up by 2. It's when the plateau pressure goes up more than what you've increased your PEEP. This means your driving pressure is increased and you're likely not in a safe zone for PEEP. Again, this is I don't have any technology to set PEEP. I'm just going to go with that kind of thing. I do want to caution people from looking at driving pressure, because my first example was if my PEEP was 10 and my driving pressure was 10, I said I would probably increase PEEP. Some people might say, oh, my driving pressure is safe, I'm going to stop right there. We don't know that the lowest driving pressure is the best driving pressure. There still could be some alveolar collapse and tidal recruitment with a low driving pressure. So that's why I said if I'm still having oxygenation problems on a PEEP of 10 and my driving pressure is only 10, I would slowly titrate up my PEEP, just because that's what I would do. I wouldn't just accept, oh, this is the lowest drive. This is so low of a driving pressure. This is super safe. I still might be under PEEPing my patient. Yeah. We don't know the magic. We just know that driving pressure is 15 or greater, or 14, depending on the study you're looking at. Greater than 14 essentially is associated with worse outcomes. So if my driving pressure is 10, you could argue, oh, just stop right there. But I would argue that it's so low that you could still have tidal recruitment. Which means that atellite trauma you mentioned.
Right. If you take care of patients at the bedside, you should be familiar with the driving pressure concept and what it means when it goes up, when it goes down, what it should be. And because that is the lowest tech way of sort of evaluating whether or not you're doing the right thing or doing the wrong thing.
Yep.
How about asthmatics real quick, super quick? PEEP and asthmatics. We've talked a lot about alveolar issues. How about an asthmatic? Do you use more PEEP to stent airways and bad obstructive disease, or do you not?
You want to answer first, Eric? I have an answer. But
I do not, unless they're demonstrating a dynamic airway closure. And those asthmatic patients typically are kind of a linear resistive model. And so, no, I wouldn't. And that idea that you fix auto PEEP in that type of linear resistive model, meaning that the airway hasn't collapsed shut, it isn't going to help yourself. So I think the poor man's test for that is if you have this air trapping that is resulting in an intrinsic PEEP. So let's just put numbers on it. Let's say PEEP is at 5, total PEEP is at 12. If you increase your PEEP to 10 and the total PEEP goes 17, you have this kind of...
They're not an absorber.
They're not an absorber. They have this linear resistive model, essentially.
Yep. Say that again, Eric. Backtrack maybe 2 sentences and say that again.
So the poor man's test for that, essentially, is to understand what is happening in the relationship between set PEEP and total PEEP.
Right?
And so if you have just an airway that is bronchoconstricted, and it's bronchoconstricted, we'll just say equally all the way through the tracheobronchial tree, right? Just making that up in our head, understanding large airway versus small airway. But it's just linearly bronchoconstricted. If I had a set PEEP of 5 and a total PEEP of 10, and I increase the set PEEP to 10, because I heard somewhere that increasing set PEEP corrects auto PEEP, right? That is a common misnomer and really unfortunate. If I increase the set PEEP to 10 and the total PEEP goes up from 10 to 15, then you have demonstrated to yourself
You've not accomplished anything.
yeah, you haven't accomplished
No,
anything.
you've just driven up plateau
entire
pressure as
pressure
well.
graph.
Yeah.
You've just increased alveolar pressure and hyperinflation. Yeah.
But if that patient had more of a disease process that was not linear, was the air trapping auto PEEP was due to a dynamic airway collapse in which the pressure inside of the airway was lower than the pressure on the outside of the airway, and the airway collapses. So we'll just take a COPD patient that has easily collapsible airways, right? And they have an auto PEEP, and your set PEEP is on 5 and the total PEEP is on 10 is at 10. If I increase the set PEEP on that particular patient to 10, then the total PEEP doesn't change because all of
They're an absorber, like Tom said.
Or even if your total PEEP goes to 12, even if it goes to 12, the
It's a
bottom
little
line
bit.
is you're now within 2 centimeters of water of total PEEP. I would stop right there and be
Right.
like,
Stop. Yep. Time out.
And
Yep.
in that case, you did, quote unquote, stent the airway open with the airway pressure applied from the ventilator, right? But as a general rule, stenting the airway open doesn't apply
Right.
generally across the board. They have
Yep.
to demonstrate that.
But may in a stop a small subgroup of people with chronic COPD and floppy airways.
Well, you're also talking about airway closure, which does not necessarily have to isolate itself to asthma either, and this is what Tom was referring to earlier
Right.
too. What 30 to 40% of mechanically ventilated patients have airway closure, right?
yeah,
So
it's very
somewhere
common in
around-
post-cardiac arrest patients too. Like I honestly think we should do a whole episode on airway closure.
We will. Absolutely.
But I just want to quickly add, because I know we're getting near the end of our timing that we wanted to sort of stay under, but I wanted to agree with Eric publicly. And this is also another caveat, because earlier I said if they were hypoxic failure, I would start them on a PEEP of 10. If they were hypoxic and hypercarbic due to an asthma exacerbation or COPD, this is the different caveat. This is the patient where I would get my ventilator settings set up on a low PEEP of like 5. And then one of the first maneuvers I would do, I mentioned the first thing I would do would be a plateau pressure measurement. I would also do an expiratory hold to assess total PEEP and do exactly what Eric had suggested, that if my total PEEP is significantly higher than my set PEEP, then I would increase my PEEP. Keeping in mind that asthma patients that are in full bronchospasm, PEEP doesn't generally crank open those airways. Like you need medication to relax those airways. It's going to be very difficult for PEEP to open up and for them to be a PEEP absorber, meaning you increase PEEP and your total PEEP doesn't go up the same amount. So I would do that. I've had many patients where we have put them on PEEP of 0, and that usually blows people's minds when they see a PEEP of 0. They're like, why then a PEEP of 0? And I just tell them, I said, go do an expiratory hold. And they do an expiratory hold and they see that they have a total PEEP of 12. And then I'm like, increase the PEEP by 4, and they increase by 4, and now the total PEEP is 16. I'm like, do you understand now? I'm like, PEEP is doing nothing but increasing hyperinflation.
That's a
It's
good
just
example.
increasing alveolar pressure. So it's always worth noting that even if you set 5 on an asthmatic patient and your total PEEP is 12, you can try increasing PEEP to see if something splints open. But most of the time in a severe asthma situation, you may find lowering your PEEP is going to be more beneficial, but also lowering your rate. Some people hyper focus on like, oh, they're hypercarbic, I need to give them a fast rate.
my-
It's like, no, lower the rate. Like we're talking like 10 to 14 breaths per minute, and give them a bit more tidal volume. Like they're not ARDS. Give them 7 or 8 mils per kilogram, up to 10 mils per kilogram, depending on how severe, as long as you give them sufficient time. And that's the other point I want to make about PEEP, maybe before we wrap it up, is that when you have auto PEEP on a ventilator, clearly you're not exhaling all the way. The biggest mistake you can make is go, oh, I have auto PEEP visually on the ventilator, I'm going to turn my PEEP up, when it's really a timing problem. Like it's not an airway problem, it's a timing problem. If your rate is set at 28 and you have auto PEEP, you don't start titrating your PEEP to fix that. You lower your rate. In most situations where you have total PEEP, lowering your rate eliminates this total PEEP, like the PEEP above set PEEP, their intrinsic PEEP. It eliminates that by just lowering your respiratory rate. So distinguishing those two, distinguishing airway issues versus a timing issue. And of course, those airway issues are a timing issue. There's only so low you can go in an asthma patient before you're like, okay, I need to still ventilate them a little bit. But just walking up to the ventilator and seeing clear airway closure, half the time, or not airway closure, sorry, air trapping, half the time is just lowering your rate a bit and sort of reestablishing. Sometimes lowering your rate, your CO2 actually gets better because you're not trapping it as much.
Yeah, we're going to have we'll have an episode on taking care of the critically ill asthmatic.
Yeah, that's a good idea.
That's a mortifyingly
Complex.
difficult patient to take care
Yep.
of. And to be honest with you, the ventilator is usually the problem, right?
Yep.
And this is sort of why we drag our feet on intubating an asthmatic, is because they'll survive their asthma, they'll survive their pH of 6.9, they'll survive hypercarbia. But by God, they will not survive hemodynamic collapse from cranking the rate up to try to fix the pH. All that being said, we are out of time. Anybody have any parting shots they just want to throw out there real quick? We've talked a lot about different things. Maybe a higher starting PEEP for at least some patients, maybe most patients, than we have traditionally done.
So, well, I think, so there is, you brought it up geographically, right? Because I'm not sure who this is going to reach, right? So we were talking about, like in North America, BMIs are 30 plus. In the vast majority of these patients, right? So understanding that distending pressure, I think is where we need to, you kind of need to put yourself into. I think if you are in Asia, perhaps, where BMI isn't the epidemic that it is here, and we are talking about these aggressively high PEEPs because we are used to dealing with these set in this cohort of patients, then maybe that 10 maybe is down more towards your 8, Keith. And I think, really understanding distending pressure is where you start from, right? And understanding that idea and why, we see patients that are typically require a higher PEEP to reach a distending pressure of the alveolus, right? And so, each patient is unique, and you need to put some thought into it, but you can apply these principles, I think, would be my parting shot in that.
Excellent.
I think your point is the good take-home point. You need to put some thought into it. I think if we're just going through the motions and putting everybody on the same settings, we're ignoring the fact that patients are individual. And the least you can do to individualize PEEP is consider if 5 might be too low for this patient. Mm-hmm. I have a patient who looks quite large. Should I start them on a PEEP of 5? Probably not. And again, maybe you don't understand transpulmonary pressure. Stay tuned for that podcast episode. But
future.
Think about it. Think about it physiologically. Does this make sense that this person should be on such minimally low settings for PEEP?
Customize your ventilator approach to the patient.
Yeah. And dose it, right?
And dose it. Dose it. All right, fellas. Thank you so much. Thanks for joining us for episode number 1. We appreciate your participation. We hope that you enjoyed this. Many, many, many more episodes coming up and that have been planned. Thank you, Eric, for joining us today. Thank you, Tom, for being our co-host. And we'll chat with you later.